Dr. Twyman, you are my first guest other than Dr. Donald Lehman, who I have been with for 20 years. So
Thank you for
that makes you
having me.
important. That makes you like the second most important person.
Excellent. Well, it's a pleasure.
You guys, I am so excited to introduce you to Dr. Michael Twyman. He is a cardiologist. He is a cardiologist in the practice, and he's the director of cardiology for the Institute for Muscle-Centric Medicine. And he is just very, very sharp. Okay. So with all that being said, please tell me a little bit about you, your training. I kind of sprung this on you because I told you we were going to talk about lipids and LDL and lipoprotein A, but actually I want to hear more about you.
Sure. So I'm originally from St. Louis, Missouri. I did all my undergrad training in the Midwest, did my medical school training at St. Louis University School of Medicine. And after I finished 3 extra years of internal medicine, I was in the Navy to do the payback for my health profession scholarship. And so the Navy had paid for my medical school, so I owed them 4 years of active duty. Got shipped off to Naval Hospital Beaufort in South Carolina, where I was ultimately the internal medicine director, running the whole department. And it was a fantastic experience. Got some leadership experience. Ultimately got some business experience. I went back during my active duty days and got my MBA through Webster University. And then when I completed my active duty time, I'd always wanted to be a cardiologist. So I came back to St. Louis and went back to my medicine training and did 3 more years of cardiology.
So why cardiology?
I was always fascinated by the heart and the cardiovascular system. It's also something where, in the early days of cardiovascular care, there wasn't a lot that they could do to save people's lives. And now you can basically do almost everything minimally invasive, and it's just absolutely fascinating how fast the field changes. And no day was the same. I mean, if you wanted to take care of real sick people in ICU, you could. You wanted to do procedures in the cath lab, you could. You wanted to round in the hospital, you could do imaging. You could do an office. So, yeah. Well, ultimately, I don't say I got tired of it, but after a few years of doing all the gamut of general cardiovascular care, I decided to really want to focus on heart attack and stroke prevention, and now just outpatient focused.
So you did a residency in internal medicine. Then you served for 4 years in the Navy in internal medicine. So you guys, this is a lot of experience. Then you did a cardiology. So cardiology is a fellowship, right?
Correct.
So that's 2 or 3 years.
That was 3 more years.
3 more years. So you did 4 plus 4 in internal medicine plus worked for 4. So that's 8. Plus another 3, 8, 9, 10, 11. You guys, this is a very highly trained physician. And I think that's one of the reasons he's so good is because he's so well trained. And you guys have to understand that with so much information and the web with information overload, every expert is not equal. I will only bring to you highly trained experts that I trust myself. And I trust with your well-being. And that is the only people that will be on the show, just so you know. And Dr. Twyman is one of those people. We've been now friends for a few years, and many of my patients see him. If you are in my practice or applying to be in my practice, you will also have the opportunity to talk to Dr. Twyman. So why cardiology? Like, what was it about cardiology? Because that's a really kind of I don't want to say mathematical, but it takes a certain kind of brain. Wouldn't you agree? Kind of.
Yeah, I would. When you say mathematical, that's kind of funny. I mean, that was actually my undergraduate degree. I'm not a biology major. I'm a chemistry major. I was a mathematics major and was almost a physics major. And once I got into medical school, I let the physics part go. So yes, I had a very kind of analytical mind and looking at numbers and deciding how to tweak things in the ICU. It just made sense to me. And then as going through medical school, you get exposed to all the different specialties. And I was very interested in certain procedures, but just thought I didn't want to be in a OR or cath lab all day long. I still like to take care of patients in the outpatient world. So cardiology just fit generally well with that. But for a long time, there was actually a big decision between was I going to do pediatric cardiology or was I going to do adult cardiology? And I really love the kiddos and such. And, congenital heart disease is absolutely fascinating, but in the end, it was just emotionally too hard to see the kids suffering. And so I said, like, well,
Totally.
I'd rather take care of the adults. Sometimes they do a lot of that stuff to themselves, and maybe I can say I can help to prevent that or reverse it. So
That's really interesting. And, you and I were talking that cardiologists, people think of cardiology as this older person's game, right? Like it's not, it's not an older person's sport, is it? Or it's not what did we say? It's not a,
yeah, it's a young man's game. It's not
a
just
young
an old
man's
man's
game.
sport.
Cardiology is a young man's game, but we always think about going to a cardiologist as, you don't go until you're 55 or 65, which I guess is technically young man's game. But really, a lot of the heart disease issues, plaque, that starts, when does that start? 20s, 30s?
Yeah. Your teens and 20s is when you're starting to lay down the foundation that, if you don't change things, you're going to start getting plaque buildup and things will start showing up in your 40s, 50s, 60s.
Right. So you guys understand that while we think of cardiology as this later in life physician that you see, that's not actually accurate. Just like the same kind of medicine that I practice, if we can get you guys in earlier, much earlier than what you would anticipate, then you can actually change the trajectory of aging. What would you say in terms of when patients come to you, when they're on the younger end, what would be the top 3 tests that you would do? So there's the blood tests and then the imaging tests. What would you say the top 3 of each? Or maybe that's too many imaging tests, but top tests.
So top test, I would say if you're under the age of 40, generally probably the top 2 non-invasive tests would be a carotid intima-media thickness scan. It's an ultrasound of the artery on the side of your neck. And that artery provides blood flow to the brain. And the walls are supposed to be very thin, paper thin. The thicker the walls of the artery, the more inflammation in the wall of the artery, and the more likely plaque is going to start building up there. And you can actually get a vascular age. Yours, I think it was Virchow, and then later Osler said, a man is as old as his arteries. So you can be 25 years old, they scan your neck and tell you you're a 55-year-old, you're basically 55 unless you start doing stuff aggressively to stabilize that inflammation and plaque so that you don't have an event down the road. So the CIMT is probably the number 1 thing for a younger person.
And but, I think I did one, and so did Shane, right?
You did, and yours was excellent. His was as well. Yeah, I think it was yours was a little bit better for
mine was better. Shane, if you're watching, mine was better.
Yeah. Yes.
So you do a CIMT, and that's really for everybody, right?
That's almost everybody. And even in the big, general cardiology trials, waiting for an outcome of somebody, dying from a heart attack, stroke, a lot of times they use a surrogate endpoint, and they're looking at that often as that thickness of the wall of the artery as a marker of plaque likely being laid down or not. So that is a, painless, safe test to do. Generally repeat it, once a year or so to see if things are improving or worsening, hopefully not worsening. But another test, and you had done it, and it's not done as frequently in places just because they don't know about it as much, but is looking at the endothelial function. So the test is called an EndoPAT, mostly studied at the Mayo Clinic, which is one of the number 1 world renowned places for cardiovascular care. But the endothelium is the inner lining of your arteries, and when it gets damaged, that's the first sign vascular disease is present. And this can happen, 6, 7, 8 years before the plaques can actually get deposited in the walls of the artery. So you want to go testing, well, how healthy is the endothelium? And this non-invasive test, measures the flow in the fingertips and sees how much nitric oxide your body can pump out.
That's really interesting. So we've got the CIMT, we have the EndoPAT. Are there any other imaging tests? Would you recommend a calcium score, or you typically think that those are negative when an individual is younger? Is that a routine score that you would recommend, or?
Generally not for somebody under the age of 40. A CT coronary calcium score is, not a high risk test to have done. It does involve some ionizing radiation, so you want to mitigate that as much as possible. But a younger person is not as likely to calcify a plaque. It's that's a later stage finding. So typically that test is, people over the age of 40. If you've had a family member, your mom, dad had heart attacks in their late 40s, early 50s. I'm probably going to screen you 10 years before your parents had the events. So I have screened people down, into maybe their late 20s, early 30s with a calcium score test, but that's uncommon. So typically it's, people over the age of 40, 45 is when you start thinking about that particular test.
And then what about blood work? So someone comes to you and they, typically what is traditionally done? Is it just a cholesterol panel? Is that what traditional cardiologists do? And I mean, tell me, what do we do?
Sure. So I mean,
I mean, you
there's,
guys, this is a trick question because I know the
yeah.
answer, but
Yeah, we do more than the traditional, training that led us to. But most people, if they're getting a traditional cholesterol panel, which is just going to show you your total cholesterol, your HDL cholesterol, triglyceride, and generally it's a calculated LDL cholesterol or LDLC. And that's the best they had, in the 60s and 70s, but there's more advanced techniques to actually measure what transports that cholesterol around the system. And we'll probably get into that today or future chats. But, the traditional cholesterol panel, it's a good starting point, but it's not specific enough for that individual. For large populations, it probably can help predict things, but, we're very, much into, personalized, individualized medicine. And so what's going on with that particular person.
so what would you recommend an NMR, Boston Heart? What's on kind of someone comes in, I run like 22 vials of blood and that's my baseline. Do you have a baseline that you like to look at? Do you like to look at their LP little a, ApoB?
No, those are great questions. And so, yes, it's a combination of looking at the lipid particles. Those are the, basically the cargo ships that actually transport the cholesterol and triglycerides around the system. So there's different techniques. NMR is one of them. Ion mobility is another. You don't need to know the kind of the way the lab does things, but it'll actually measure the ApoB particles, and ApoB is the best predictor of risk. The more particles you have, the more shots on goal, the more cars on the highway, however you want to use the analogy, the more likely those particles are going to get retained in the walls of the artery and plaque starts building up. So you actually want to measure the particle. The cholesterol is basically the cargo inside of them. It's important, but it's actually more important to know what the particle count is. And so getting, the actual LDL particle count or the ApoB count, then, a whole host of inflammatory markers, high sensitivity CRP, myeloperoxidase, LPA2, F2 isoprostane, over creatinine, which is a metric of oxidative stress, urine microalbumin creatinine ratio, which, people who are diabetic are familiar with that test. The higher your protein in urine, the more likely the diabetes or prediabetes is damage your kidneys. But protein in urine would be a marker of endothelial dysfunction. So if you're leaking protein into your urine, it's very likely that the heart artery endothelial function is also abnormal. And then there's ADMA and SDMA. Those are markers of somewhat endothelial function. So if you have really high ADMA, you're likely to have very low nitric oxide. So you may have issues with blood pressure and erectile dysfunction, all the things that endothelial dysfunction can lead to. Then there's full thyroid panel. It's much more, as than just a TSH. What is the body actually pumping out? Are you making antibodies towards your thyroid?
There's a lot.
There's
you
a lot
guys,
of things.
there's a lot. So what I love about Dr. Twyman is he's very thorough. It's not just your cholesterol panel. It's thinking about the person as a whole. What are some of the tests that they need to do? He's run all these tests on me and all these blood markers on me. It's just interesting. It's really interesting to see. It's interesting to see what supplements, how your diet affects. One of the things that, we've talked about is that some individuals, there's this big hype about cholesterol. And it's kind of interesting. We've got two groups. You have the group that says cholesterol doesn't mean anything. It doesn't matter. It's okay if it's 400, right? And that's crazy. And then there's the other group that says, oh, well, cholesterol means everything and everyone should be on a statin. Would you kind of agree with that?
Right. And I mean, there's people that have joked that, statins should be in the water. And, and there's people who say, statins are, absolute poisons and nobody should be taking them. And, obviously it's going to be somewhere much more in the middle. And it's, I tell people, statins are tools, high risk people, people already had their, the chest cracked open, they got stents, they've had bypass, they've had strokes. They're just trying not to have another event, and statins are a very good tool at preventing second events. Somebody's younger, especially a female, statins maybe is not the right tool for them, unless they have a genetic abnormality that really pushes up their ApoB containing particles.
Right.
But cholesterol, is a very important molecule. Every cell in your body needs it. Mother Nature or God or whatever people believe in, they didn't put cholesterol in you to give you heart attacks or strokes. It's when your immune system kind of fires off and these Arteries are getting scratched up, and then the cholesterol is getting retained in the walls of the artery, and the plaque just builds silently like a little pimple or volcano on the artery. And over time, if you don't shut down those pathways, that pimple or little volcano erupts, and that's what the actual heart attack or stroke is. And so back to your original question about, does cholesterol matter? It always matters because there's always going to be a sterol inside a plaque in the walls of the artery. Now, why it gets stuck there, retained there, that's somewhat of $1 million question. I don't think they fully elucidated why the particles are stuck there and releasing their payload into the walls of the artery. But the people who make a dietary change and their total cholesterol goes to 500 and their LDL-C goes to 400, and they say like, well, it doesn't really matter. I have low triglycerides and low HDL. I'm metabolically healthy. The answer really is what is your arteries actually going to do with that information? Just looking at what's in your blood doesn't tell you where those particles actually go. Doesn't
That's
tell
a
you
really
that
good point.
it doesn't say that they're absolutely going to deposit in the arteries. They may. So that's why I say, do the test, that you can get done in my office or other places, looking at the endothelial function. Is your endothelium healthy? The answer is yes. Those particles are likely not getting retained in the wall of the artery. What is the artery and your carotid doing? Is your intima thickening? If it is, those particles are getting retained in the walls of the artery and are about ready to lay down plaque. I see some of these people on social media, they post their calcium scores and say it's 0 and like they think they're good to go. But, by the time you calcify a plaque, that's been there for 10, 15 years sometimes, and you have a lot of soft vulnerable plaque. And that's the stuff that doesn't pick up on a calcium score test. The soft plaque is the stuff that ruptures and causes heart attacks. The hard plaques, for the most part, don't rupture. They'll cause symptoms when there's a severe enough stenosis in the artery. People get chest pain, shortness of breath when they exercise, but a hard calcified plaque generally isn't the ones that cause the heart attack. So having a calcium score of 0, good, but it's not sufficient enough to say you're truly low risk.
That is really important and very smart, Mike. What Dr. Mike is saying is that it's not just your blood. It's not just looking at your blood, but it's also looking at the physiological function beyond that. And I think that that's where people are missing, that they'll say, okay, well, this is your, LP little a, or all these other markers, say that there's a hyper responder from a ketogenic or a carnivore style diet. Well, is it bad? Or, can the body manage it? Can the body manage that information? There's only one way to know. And it's not about guessing, and it's not about just looking at the blood work. You have to look at the blood work with imaging and look at the big picture. And that's ultimately how you determine what works well for an individual. And that's smart medicine. It's understanding what are the potential outcomes. So if you like this video, please subscribe to my channel so you get updates, and like, share, ask questions. Dr. Twyman is going to be on many more times. We are just starting this series. Go follow him. I am going to put his information in the links below. And again, as always, I know everybody is vying for your time. Really appreciate you listening. We really want to educate. It is your right to have solid and good intel. So thanks again.